Hello, everyone. You're so welcome. Thanks for joining us this afternoon. I'm Maureen Flynn, and I'm a Director of Nursing in the OBNSD and the National Quality and Patient Safety Directorate. You're here with us, live connected to the IADNAM Conference in the beautiful Sligo at Ross's White. Thank you for joining us. Will we have a lunch or a coffee or a sandwich, something beside you? Thanks to those who are joining in groups for their lunchtime gatherings. Today's session is Creating Tomorrow Today, how to prepare for a radically different future. What you will learn from our guest speakers are how to mobilise people around the potential for a radically different future so that we are better prepared for that future. Hopefully, you'll leave with ideas and inspiration to take away with you. So now it's my real pleasure to hand over to my colleague.
Thank you very much, Maureen. So my name is Orla Healy and I'm the National Clinical Director of Quality and Patient Safety in the HSE, and I'm delighted to be at the IADNAM Conference here today again this year. It's always a tremendous gathering of clinical and thought leaders, highly appropriate given that quality and patient safety is everybody's business. And as the single largest professional grouping in healthcare, that's a lot of business. And we are particularly grateful to IADNAM for collaboration with us on this webinar and allowing us to borrow from their high-profile international speakers. So I'm going to hand over now to my colleague, Fiona, to introduce herself.
Thank you. Good afternoon, everybody. I'm Fiona Hanrahan, and I'm the Honorary Vice President of IADNAM. I'm really delighted to be here with you, and having had a really exciting and energising morning in the conference hall. We're here in the Radisson Blu Hotel in Sligo. We've 220 delegates present with us at the conference, which is enormous numbers. And the hall felt electric and alive this morning, I think it's fair to say. We had an opening address from our Honorary President, Eileen Carruthers, who quoted both Yeats and talked about Shane Filan. So in her speech managed to get a lot of messages across, and in the middle a very thought-provoking message around change and care and looking after ourselves. That was followed then by Dr Ger Shaw, who many of you will know from the OMNSD, and Ger talked to us about systems leadership. And so she gave a really powerful, I think, talk about using systems for change and systems for leadership, and gave us lots of thoughts about how to be the leaders in systems. And then we had a break. And then we had a patient advocate, Mrs. Margaret Murphy. Margaret is an amazing woman. Her son Kevin died due to medical misadventure in 1998. And really since then, Margaret has worked tirelessly as a patient advocate. To her own tragedy of losing her son, she's built herself into this amazing advocate for patient safety, openness, and open disclosure. And she works with the World Health Organization on the Patient Representative Forum. And she held the room. There was tears. There was a lot of people who found her talk so from the heart, so powerful and so brave. And she got a standing ovation. She's absolutely a phenomenal speaker. And then we were absolutely delighted to welcome Dr Helen Bevan to the stage. Dr Bevan is a leader of large-scale change, an innovator, an activist in health and care. She's the current Professor of Practice in Health and Care Improvement at Warwick Business School, the University of Warwick, and a strategic advisor to the NHS Horizons team. She spent more than 3 decades working in England's National Health Service, focusing on large-scale transformational change. She's led and facilitated many nationwide improvement initiatives, including those in cancer services, urgent and emergency care, and dementia care and treatment. Helen acts as an advisor and a teacher to leaders of health and care in many other countries. Helen has the ability to connect directly with thousands of people working in the point of care, and as well with people who use the services. Helen is one of the top social influencers in health and care globally, reaching more than 1 million people each month through her social media connections, selected presentations, commentaries, and her blogs. And I have to say that having spent the hours in the conference room with Helen this morning, it was absolutely powerful. The room was electric, and I think every single delegate was making notes. They were capturing your slides. They were listening intently. There was talk going on. You absolutely energized the room, and I really want to thank you because I think you had an enormous impact. And when we look at the theme of our conference, which is healthcare at a crossroads. I think you really have directed us on the right part of the crossroads, and I really want to thank you for that. So delighted to hand over to you, Helen. Thank you so much on behalf of IADNAM and everyone who's present today.
Thank you.
Thank you.
Oh, it's been an absolute pleasure, and I mean, I'm amazed at the IADNAM conference that there are, so many leaders here from nursing and midwifery with, like so much kind of, ambition and energy for different kinds of conversations. And what I was going to do now is I want to make a presentation for about 20 minutes. Which is based on some of the content from the workshop that I ran at IADNAM this morning, and a much shortened version of it. And what I've chosen to do is to focus specifically on the aspects that I think will be relevant to people who are passionate about quality and safety, like I am. So let's get going. So, this talk was called Creating Tomorrow Today, How to Prepare for a Radically Different Future. And what I want to show you now is some work and a framework that I've developed collaboratively with Joran Henriks. And Joran is a leader in Jönköping region in Sweden. And Jönköping is a place in the south of Sweden that gets like spectacular outcomes in terms of the health of its population. And it does this because just the way it thinks about integration and integrated care and health, if you like, being part of life. And I've been working for about 10 years with Joran to build this framework, and hundreds of leaders from all over the world have helped us to develop it. And I'd like to share that with you now. So I took this picture from colleagues in Jönköping and Sweden. So, if we're talking about a radically different future, what kind of system, what kind of health and care or health system do we want? And what we see here in the bottom left-hand side is the health motto of Jönköping region. And it says, for a good life in an attractive region. It doesn't say, every one of our patients to get safe, effective care. It says, people being able to have a good life, of which health is a core component in an attractive region. Why shouldn't we live in a nice place? That adds to our health. And above that, I've got a quote from Paul Bertolden, who's one of the really early gurus of quality improvement. And he says, every system is perfectly designed to get the results it gets. And what we mean by that is that if we have a system where there are significant issues around the safety and quality of our care, it's because the system's designed for that. So if we have a system, as in Jönköping, where we're designing the system so that everybody gets a good life in an attractive region, then we will get different results. So again, we're thinking about how we measure our success. And what Jönköping would say is we measure it in lives and the quality of life that people have and in health. So I think, again, it's worth looking at the kind of philosophy that Jönköping has that enables these great results. So the whole idea of it is that for all of us who work in healthcare, we want to continually improve the daily work we do, and we want to invest in innovation, and we want to be learning constantly. And rather than having, lots of complex rules for doing things, let's have a few simple rules and basic principles that unites everybody in the same outcomes and also in systems thinking. So their whole philosophy is the major focus should be about supporting people to have health and in their daily life. So it's not just the health and care system, but people across the system that are enabling that, and that's the major focus. So where people need support and rehabilitation, that becomes available, but it's done on a place-based basis, and it's in the local community. And then we move into formal health and care systems with primary care and seeing specialist care as only a small part of a system that is designed for health in daily life. So, when I was talking there about young shipping, I talked about how we want a set of simple rules, if you like, that everybody in the system can work behind. And I think there's a bigger principle behind this. So if we want to get a large group of people in a system to behave differently, and we want to get everybody moving together in a coherent direction, then there's at least two different approaches that we can follow. So one of them is a more top-down approach where we have very clear policies, we have an approval system, and in a sense we do a top-down cascade. And if we're going to work in that way, then we will create clear policies, a clear operating system, and anybody that's got a formal leadership role, we hold them to account. Okay? Let's contrast that with the kind of young shipping approach where we align people through simple rules. And what we're going to do is we identify a few simple rules that everybody in the system, whatever our role is accountable for, and we operate in conditions of much greater individual freedom. But everybody understands that these are the rules, and we work with them. I put this quote here from Michael Doublevock, and he says, we should contrast between what he calls complex rules, which is number one here, and simple rules, which are number two. And he said, very often, an effective set of simple rules will lead to behaviour that is complex and intelligent. However, having a set of complex rules, like number one here, often leads to dumb and primitive behaviour because people work the rules. Everybody does. It's the nature of them. I want to show you a practical example of simple rules. So this is from Oldham, and Oldham is a district in the north of England. And when it came to Oldham's approach to COVID-19, rather than having very complex policies and procedures, they created a set of simple rules, and there were just 5 of them that everybody stuck to. So we keep current with the guidelines, and we defer to experts. We coordinate rather than confusing, and we stay calm, and we keep calm and we stay kind. And everybody understands that, and we all move forward together. What I shared this morning at the conference was the 7 simple rules that Joran and I have developed with help from a lot of other healthcare leaders. And the idea and the principle of this is that if we follow these 7 simple rules and focus on these 7 things, then in terms of the work that we're doing today, we can create tomorrow at the same time. And what I'm going to do just really quickly to go through these. The first one is about defining our shared purpose. So first of all, we have to be clear about who the our is. So typically, the our needs to be everybody who is part of change or being impacted by it. So it will include, people that use services. It will include families. It will include communities. It will include all kinds of health professionals. It might include students, support workers, leaders. But just being really clear first of all the our, and then we think about shared. So we think about lots of things divide us because we're very different people, but what unites us, what brings us together. And then finally, we think about the purpose, which is about the difference that we want to make that is meaningful to all of us. So being much more deliberate, whether we're talking about a work team, a task and finish team, a quality improvement team, about defining our shared purpose. And, those of us that work in quality improvement, very often, we follow a methodology which says start with aim. And aim is really important, but actually we need to start higher than that, okay? Because we need to start with the our and then the shared purpose. And only when we have that, we have a sense of purpose, can we create the aim together. Okay? Number 2 is about rooting our transformation efforts in a sense of belonging. And one of the things that I said this morning is that when I think about my improvement practice now compared to, say, a couple 2 or 3 years ago, one of the things that I'm making much more effort with is building a sense of belonging. So if we bring people to be part of an improvement team, and we've got to create a sense of belonging for everybody in that team. And that includes people that use services who might be, people with lived experience who are
part of the team, or people who work in frontline roles. Everybody, feels that sense of belonging. Number 3 is predict and prevent, and in the same way that I showed you the young shipping triangle, where there's so much focus about working upstream, okay, in terms of supporting people in their daily lives. So we start on improvement projects or our work an earlier stage upstream in the intervention or care process. Number 4 is about supporting people to build their agency. And what we mean by agency is our sense of our power or permission to actually make change happen. Very often, again, in the world of quality improvement, we train people in improvement skills and capabilities. We then send them back into clinical environments, and people don't feel they've got any agency, so the change doesn't happen. Okay. Number 5 is about embracing contradictions and tensions, and understanding that when we're working in complex environments, very often there's big contradictions or big tensions in the work, and we want to embrace both. So again, in quality improvement terms, we want to improve quality and we want to reduce cost. We want care that's evidence-based and clinically led, and we want it to be patient-led. We want to do small-scale changes that really make a difference, and we want all the small-scale changes to be part of large-scale change as well. We have to manage the tension and the contradiction between small-scale and large-scale change. Okay, I'm going to come back to number 6 because that's the one I've chosen to focus on now. Just to say that the final one is number 7, which is about again small-scale, large-scale change. So we have to work with small-scale changes. It's the only way we change the world. If all we have is lots and lots of small-scale changes, we've got 1,000 flowers blooming, loads of duplication, no ways of transferring the learning from one to the other. So we of course want small-scale change, but we need to do them within a bigger scale framework that enables us to make accumulated improvements and to learn between projects. So the one I want to come to now with a little bit more information very quickly is about unleashing learning as a power for transformation. So I want to talk about this, first of all, by talking about psychological safety. So one of the things that we see often in the NHS in England is a sense that we want people that work at the point of care to be undertaking improvement work. We want everybody to see improvement as part of their daily job. And very often people are like, oh, have I got permission? Will I get in trouble? Can I take a risk? Will I be supported if I make an error? So we really need to think about psychological safety, because we cannot create the conditions for the really strong improvement work unless we build a climate of psychological safety. And Amy Edmondson here, who's the kind of global guru on psychological safety, defines psychological safety a shared belief held by members of the team that the team is safe for interpersonal risk taking. So if we want people to plan, do study act cycles and do improvement projects and change the system, then it's got to feel safe. A team climate characterised by interpersonal trust and mutual respect, in which people are appreciated for the unique things they bring and going back to sense of belonging and are comfortable being themselves. So one of the things that Amy and her collaborators did in 2019 was to develop a psychological safety scan. So Amy and her colleagues introduced this scan. And what this scan does is enable organisations and teams to assess, where they are with psychological safety, so that if we're doing some work to increase our levels of psychological safety, we can gauge it over time. And what I did in the workshop this morning was I showed the 4 different categories that are part of the psychological safety scan. Willingness to help, people being willing to support each other. Inclusion and diversity, the degree to which people can be themselves and are welcome for being themselves. Attitude to risk and failure, to the degree with which it's okay to make mistakes. And finally, open conversation, the degree to which difficult and sensitive topics can be discussed openly. And I asked the teams, asked the tables at the conference this morning, which one of these 4 do you think that in healthcare, psychological safety scores are lowest? And Bruce Table's got the answer correct, which was attitude to risk and failure. What we've got here, and this comes from a book called Humanocracy, Creating Organisations as Amazing as the People in Them. It's one of the best-selling leadership books of 2020 by Gary Hamel and Michele Zanini. And what they looked at was, they called it a hierarchy of capabilities. And what this is about is, if we want to maximise the contribution that everyone in the organisation can make, we need to build these capabilities. And the higher we go in building these capabilities, then the greater contribution that everyone can make. What you've got in the bottom half of the pyramid here are the kinds of qualities, the capabilities that those of us that are in formal leadership roles, we can command them and we can expect them. So, for instance, we can expect people to be obedient. We can say we can reasonably expect people to follow the rules, to follow the processes, to follow the clinical pathway, to follow the standard operating procedure. We can expect people to be diligent in that we expect people to come to work on time and do a full day's work or do a full session's work. And expertise, we can expect people to have the skills needed for the job and or be willing to learn them. Okay, those are all things that are really important capabilities, and people in formal leadership roles, we can expect and command that. However, when we go up higher, we go into qualities that we can't command, that people have got to want to do them. So, we want people, particularly if we want quality improvement, to take initiative. We want people to be creative and to come up with good ideas for doing things in different ways for patients. And then look at the capability right at the top. Okay, it's daring. It's about risk taking, and it's about being courageous. So compare that with what we just said about psychological safety and people feeling that risk taking and failure, okay, is the area that they feel least confident about in terms of psychological safety. So there's a direct contradiction between needing to feel daring, ability to take risk, and it being the area of psychological safety that we feel is weakest. So about 10 days ago, Amy Edmondson published a new book, which is called The Right Kind of Wrong. And I think this is a fantastic book, and it really takes on a lot of the ideas around psychological safety and learning from failure to a new level. And what she does is actually contrasts 3 different kinds of failure. So the first is basic failure, and this is the kind of failure that, the procedure is clear and somebody makes a mistake. We're careless, we didn't know the procedure. Okay, compare that with complex failure. So complex failure is caused by when multiple factors come together and at once and create failure. And if one of those things hadn't failed, then the failure wouldn't happen. So again, you think of things like one-site surgery. Okay, classic example. Okay, many factors led to that, and if any one of them hadn't failed, the surgical error wouldn't have happened. And often with complex failures, it's the result of a complex system that it's really hard to manage or understand as a whole pathway. And the thing about basic failure and complex failure is that both of them are errors. And we can maximise the chances of them occurring by paying close attention and catching mistakes, and use of checklists, better teamwork, and applying the principles of psychological safety. All the things that we learn when we do safety training in our health and care organisations. Okay, but that's different from intelligent failure. And what Amy says, intelligent failure is the kind of failure that we should encourage. Okay? Because it's the kind of failure that comes from thoughtful actions or experiments, and it's the kind of failure we need to try things out because we don't know if they're going to work or not, and it results in useful learning and allows us to move forward. And this is what Amy Edmondson says about the criteria for intelligent failure. It's the kind that leads to unexpected discovery. Okay, it doesn't cause harm in the way that error would, and it generates new learning. And it occurs when we don't know the answers in advance and we have to try things out. And intelligent failures are not errors like basic failure is and complex failure is. and she sets out 5 criteria for intelligent failure. You know, what are that set it apart? Number 1, it takes place in a new territory, so it's an area where we haven't done things before. And we don't have ready-made answers. Secondly, it's opportunity driven. So we've got an improvement project, we've set an aim, and it moves us towards it. Number 3, it's informed by prior knowledge. We've done our homework. Number 4, we test it as small as possible, and we do a lot of small cell scale testing before we do a full scale launch. And finally, we learn from it. You know, we build a learning system around it. So final thing I wanted to just say is when I look at organisations in the National Health Service in England that are doing really well at intelligent failure, what they have is what I would call a Trojan mice strategy. So we've invested in improvement capability across the organisation, and we have lots of people who have got both the improvement skills and the sense of agency to test out lots of small, well-focused changes to practice intelligent failure and to address complex problems. And these Trojan mice nearly always work better than large-scale pilot and rollout projects, what we call Trojan horses. And again, lovely quote here from Harold Jarchi. He says, Trojan mice are small, well-focused changes which are introduced on an ongoing basis in a way that's inconspicuous. And they are small enough to be understood and owned by everybody, but their effects are very far-reaching. And he says, collectively, a few Trojan mice will change more than one Trojan horse ever could. So, you know, avoiding these big Trojan horse pilot and rollout projects and having a kind of army of Trojan mice around the organisation. And again, the organisations that I know in terms of doing the best work in quality improvement, this is how they're doing it. So again, what we know about Trojan mice is that organisations that work with the Trojan mice approach, they practice an intelligent failure across their organisations, because these Trojan mice are trying things out, they're failing early, and they're failing greatly. And I just put this little diagram in here, you know, over a project timeline, that what our Trojan mice are doing are testing things out with intelligent failure on a very small scale basis and learning. And what we're not doing is doing big Trojan horse pilots and rollouts. By the time we get the information back, it's just too late, and it can lead to error. My final slide, just to say, you know, think about your own work. Okay, you know, in your improvement and patient safety work. Okay, how can we be creating today, tomorrow? How can we really be building a strong sense of shared purpose? How can we create this sense of belonging so everybody feels part of that shared purpose? How can we go upstream in our work, like Young Shipping does so brilliantly, so that we're intervening much earlier in a care process or an intervention? How can we build our own agency to feel that we've got the power and the permission to make change happen and support others to build their agency? How can we embrace contradictions and tensions and understand that we often, in quality improvement work, we have to hold them both? And how can we unleash learning as a power for transformation? You know, how can we build our army of Trojan mice and practice intelligent failure? And how can we frame our small scale improvement work in a large scale framework? And I'll stop there.
Amazing, Merlin. Thank you for sharing that fabulous tooltips and a new framework for us to take away and use. We really appreciate that. As you've been speaking, I've been watching the chat box, and what people answered to our question, the magic ingredient to energize and change. Some of the things that came up that are all reflected in your framework are empowering both staff and patients in partnership. The next one, people feeling hard for the change and contributing to that change, making every contact count. I'm thinking of Trojan mice. Collaborating in a psychologically safe space, listening deeply, communicating a vision that connects to the purpose and hearts and minds of people, not just staff, but people in our population. I love the honesty of which I knew. So now we have a framework that then we can help those that are curious about how to go about it. We're going to pop the details of Amy Edmondson's book, of course, in the chat box. If not, it'll be in the slides. I love the concept of intelligent failure. So to get us going in our conversation, I'm going to ask Orla, how do you think that framework might be of use to quality and safety leads across the country in Ireland?
Yes, Maureen, I was worried you were going to ask me what I thought the ingredient was, and I was going to say ownership, as I frantically thought what that ingredient would be. And then when I saw your framework, Helen, it really, really resonated with that magic ingredient of ownership.
Yeah.
And it resonates with everything that we do as quality and patient safety leaders. We have that shared common purpose. We have that sense of belonging to the quality and patient safety community. And we try to embrace that and have the agency and the power to make the change that we need to make. And so it is a really, really elegant framework that resonates with what we're doing already. But it is so nice to have it set out in a framework, and that we can apply. It's a sense-making exercise for us.
Yeah, that's absolutely spot on. Yeah, thank you. I really appreciate that feedback from you.
Thank you. So very good. Fiona, for nurse and midwife leaders, how do you think they may take that framework? How will it resonate? How will it be used?
Well, I think it couldn't be more appropriate than it is at the moment, with the speed of change coming at us and the pace of change coming at us. I think they're going to be forced into intelligent making mistakes in the Trojan mess. We're going to have to do all this stuff in order to get the change across. So I think this is that's why I think this is just so perfectly timed for where we are in healthcare in Ireland at the moment, as we embark on this massive change coming down the line rapidly at us. And we have to have frameworks for change. We absolutely do, because it protects people and it allows them to articulate in their own minds even how they're going to approach change, and how they're going to be brave. It's a brave new world. We've all got to be brave. So yeah, I think it's perfectly adaptable to what we're doing in Ireland at the moment.
Thank you. And Helen, this week is our Open Disclosure Week in Ireland, where we are focusing on elevating the voice of patients.
Yeah.
Do you have any tips for us in taking the framework, how we partner with patients?
So one of the things that I would say, which is kind of interesting, and it's a word, and it's a word used, Maureen, is agency versus empowerment. Okay? It's a big debate in the quality improvement world, which I think is relevant in terms of the voice of patients. Because very often when we use the word empowerment, it's somebody who is often a senior leader in a system, and like says to patients or people at the point of care, we are going to empower you. We want to empower patients, but I don't think that we can empower anybody, because and I think there's a kind of danger in it that when we say we're going to empower you, it's like, I'm somebody with formal authority in a system. I'm going to empower you, and then but I can take it back at any time. So I think, the wording in the 7 simple rules, supporting people to build their own agency. So and it's kind of a nuance, but it's an important distinction. So rather than saying empower patients or empower people at the point of care, it says support people to build their own agency, their own sense of power, and their own sense of having control of their own health. And we'll think about agency. I think we can talk about it on different levels. We can talk about individual agency and we can talk about collective agency. So individual agency is like me as somebody that uses services, like feeling control over my own health, feeling that when I talk to my clinician, that it's shared decision making, that I have a voice. But if we only focus on individual agency, I think we'll never get anywhere because it's individual isolated patients. And I think we really need to think about collective agency, which is about, where we come together with a common cause and work with other people to change the system. And the power, the agency that we get comes because it's a collective, together. So I think that, again, when it comes to the worsening patient open disclosure, that distinction between like empowerment, we will empower you, we will let you have a voice, we will listen to you, okay, is very different from we will support you to build your own agency individually and collectively, because I think agency is much more sustainable. And again, thinking about integrated care, where things need to go. It's about supporting people in communities to build their own individual and collective agency. So I think that term and the way that it's framed in that framework is the way we should be thinking.
Yeah, it's very true. How do you know? I think actually it's good to make me think about the nuance of language, because I think I work in maternity services, so these are women, who are pregnant and whatever. I think it's to do with the word empowerment can be frightening for some women who don't want to be fully empowered. They want to be in partnership with you. So the word agency, I think, is more about the level of choice women want to make, the level of independence they want to have. And like we work very much, our framework is all shared decision making around care. And we want women to know they don't have to come in fighting us. We're part of their journey. So I think it's a different word. And it just has a better, I think, a nuance around it. I like the way of building towards agency as opposed to enforcing it. I think empowerment sounds like you're forcing people to take complete control of everything to do with their health. But I think women like the working with us in a teamwork, and that the whole team is with them and they're part of our team. So I really like that.
Yeah, and it's building collectives. They are that collective agency, coming together as a team.
Yeah, that was really low. Yeah.
And Helen, taking that broader then, we probably have been aware in the last day that we're introducing 6 new regions.
Yes.
We integrated 4 into the regions. So from an organisational perspective, how might we take that framework and in the instance thoughts, what would we do with those to help us?
So it's kind of interesting, and I find that from the work that I do in a lot of other countries, like we have different systems and contexts, but I think quite a lot of the problems are similar, and I think quite a lot of the solutions are similar. So I think restructuring around a different care model, I think can bring benefits. And I mean the same thing's happening in England, where we've moved to 42 integrated care systems, and I think that is a good thing. And at the same time, if you look at those 42 systems in England, you see really big distinctions. And I think that there's lots of reasons for it, because it's a complex situation. But you can really see the difference between the places that have invested in relationships versus the places that have that are focused just on structure. And of course we end up having a big focus on structure because we're public sector organisations, and we have to have our accountability set out. All those things are important, but the places that are really moving forward, okay, in our equivalent, are the places that have really invested in relationships. So it's, yes, you can change the structure, but it doesn't, changing the structure on its own doesn't create a sense of shared purpose. And another thing about shared purpose, it's it's not just about the head and the logic and what's set out on paper, but it's at the heart as well. In the sense that our new region is about really profoundly wanting to improve the health of a population and reduce inequities. So really involving whole communities around building our shared purpose, building that sense of belonging, so that the new system isn't just a formal system that does things to people, but it's a system that everybody can feel part of. So I think that in this framework, I think there are a lot of clues to the relational components, and of course we need the structures and we need the accountabilities and new ways of working. If we really want to take this to where it can go in terms of fully integrated care systems, it's got to be about relationships.
So, yeah, it's a fabulous message. And that leads me very nicely to a comment in the chat box from Magella Daly. So she's saying, and she'll now look at the presentations. She follows you on Twitter and as well in the simplicity of the diagrams and infographics. She's asking, has the framework been used in social care services anywhere that you're aware of?
No, thank you for the question. So the framework has been developed jointly with Joran and colleagues from Jönköping, and in a sense, they don't make the same distinction that we make between healthcare and social care, because it's a municipal system, and it's based on a fully integrated model. So in a sense, the 7 simple rules are based on a fully integrated philosophy. So yes, it is. It's based on that.
Actually, Helen, I would ask each of you now, having one key message to our listeners who dialed in today. Before we close out the session, we could keep this nomination going forever, but just one little key nugget or message that you would like to share. I'm going to start with you, Fiona.
I think it's something that actually Margaret Murphy said this morning. Margaret being the patient advocate, and she talked about the head, the heart, and the hands. And I think once you keep that we'll only use our intelligence, but we have the emotion, the heart, and the skills in our hands. I think with these 7 rules as well, it all just blends together to give me an awful lot to think about, actually. And for I think the future's bright. And actually, shamelessly plugging IADNAM, I think when you look at the membership of IADNAM, it really is integrated care when you look at everyone who's part of us. So I think when you look at the regional health areas coming, the way we work in IADNAM is collaborative across all areas of healthcare. So shameless plug, join IADNAM. Thank you.
Thank you, Fiona. Orla.
Thanks very much, Fiona. You even bring the doctors. My message: embrace the change. The change is upon us. Take ownership of it and use it. Use it as leaders in quality and patient safety.
Thank you.
So maybe my point relates to both what Fiona and Orla have said, which is real change. I think happens through connections and collaboration. So if you're in there's lots kind of restructuring going on around you, and you feel that I'm not part of it, or feel out of control of it. Think about the things that you can control, and find the other people that want to do the same change that you want to do, because history shows us that actually most great change initiatives, most great improvement work doesn't actually happen top down or even bottom up. It happens when groups of people with similar passion come together and start making change happen in a often in an informal way. So don't wait for restructuring to happen or opportunities to happen, and find the other people that want to do the same change and that you want to do, and just start applying some of these principles.
Brilliant.
Our time has been short together, but hugely valuable. Thank you. A very big thank you to IADNAM for facilitating, and our manager, QPS TalkTime with the National Quality and Patient Safety Directorate. Thank you all who joined us. We have good news. We have another live QPS TalkTime coming in 2 weeks' time from the National Patient Safety Office Conference in Dublin Castle. So watch us on Twitter, follow us on the website. You'll hear more details about that as we go. And don't forget our lovely little feedback survey. As you hit the red X box on the bottom of your CISPO WebEx platform, a pop-up survey will appear on the screen. We look forward to your feedback. Thanks, everybody.